Да, Галь, да, спасибо. Dear young colleagues, good morning. Let's start our lecture. Let me introduce myself. My name is Anna Sulima. I'm the professor of the Department of Obstetrics, Gynecology and Perinatalology number 1, our Crimean Medical Academy. Today, let's talk about a very serious problem of the modern obstetrics, which we know from the ancient, but we can't resolve this problem nowadays. That's why it's one of the topic of our lectures. Let's talk about the hypertension disorders during pregnancy. I hope my lecture will be useful for you and you can use it before preparing to your um, exams and to your classes. Hypertension in pregnancy complicates not so more pregnancies. It's nearly from the 4 to 8%, but a lot of women have a severe complications like preeclampsia and eclampsia, and 30% has chronic hypertensions. One of the severe complications of these disorders also eclampsia. At the ending of my lecture, we will discuss about this problem. The incidence is not so high, but severe complications due to the eclampsia is one of the reasons of the maternal deaths uh, in our country, and I hope in your country too. It's course of preterm birth, but nowadays an etiology is not clear known to the obstetricians, and I hope in the future when you will be a good doctors you will have a solving this problem. Who in the risk? What category of the females will have this problem? Young female fall increased risk. Primigravida also is one of the risk factor of the hypertensive disorders. Women with the multiple pregnancy, twins or triplets, you know about infertility and IVF technologies, when the reproductologist will perform double embryo transfer, and the incidence of their multiple pregnancies in IVF cycles is more higher than in the natural cycles. That's why an IVF technology is also one of the risk factors of the hypertension disorders. Previous hypertension before pregnancy also one of the risk factors. Also, an extragenital pathology like renal disease or collagen vascular disease also is the risk factors of the hypertension disorders in the pregnancy. Please pay attention when you discuss with the woman. You should ask about this problem, and when you know about it, you can do also to decrease the complications during pregnancy. I hope after the finishing of COVID, we will have face-to-face lectures, and I will, or during our classes, also I ask you, How to measure blood pressure, in a pregnant woman? It's very important because the corrections of the measuring help you to diagnose this pathology or exclude it. How to measure blood pressure in a pregnant woman? Automated machine not recommended. Please pay attention about this fact. Unless calibrated against a mercury sphygmomanometer in the individual patient. Appropriate sized cuff. Also, I ask about the diameter of the standard cuff. Now I have no opportunity to ask you. That's why the normal size of the cuff is 39 centimeters. When the shoulder of the woman is higher, you should use femur cuff because its diameter is more than 39 centimeters. It's very important. You should ask women to come to your cabinet and wait during 2-3 minutes to relax, to adapt to you and to the cabinet, and only after that you start to measure her blood pressure. It's very important. The measuring of the blood pressure in a pregnant woman at both arms, not only one arm, at both arms during her first visit to you like a doctor. It's very important. Palpate systolic and go 2 millimeters higher. Also, one of their rule of measuring blood pregnant in a pregnant woman. Deflate slowly 2 millimeters every second. Use Korotko 5. Don't use 4 Korotko 5 tone. Use Korotko 5 for diastolic blood pressure. I pay your attention, it's very important. Repeated measuring may be required if everything is not okay during before or a previous measuring. Ambulatory monitoring useful for white coat hypertensions. That's why when she comes to your cabinet, you should ask her, please sit down, relax, take a deep breath, and after 2-3 minutes, you can start, or midwife or your midwife start measuring blood pressure for avoiding white coat hypertensions. It will help you in correction diagnosis of this problem. It's also very important. Of course, the most common mistakes in measuring blood pressure in pregnant women, if you not to do correct rules which we discussed before. Use appropriate diameter of the cuff that does not fit the size of the shoulder. You know that the standard cuff of standard shoulder cuff is 39 centimeters. If more, please use another femur cuff for measuring, especially when your patient have obesity or another problem when her shoulder is more than standard size. Of course, the most common mistakes is not enough time to adapt patient before the first measuring. It's also very important, and we discussed about it before. A lack of control of the asymmetry of blood pressure on the right and the left hands. That's why it's very important of the measuring blood pressure on the both arms. I usually ask you about it on exam because it's very important. That's why lack of control of the asymmetry and blood pressure measuring only on the one hands is a common mistake. Please pay attention. Incorrect position of the body and arm on which measurements taken. She should sit down, put her hand on the table, relax during 2-3 minutes and start of measuring the blood pressure. Of course, inaccuracy of instruments for measuring blood pressure. That's why you should check your measuring blood pressure instruments and you should be sure in it accuracy before the procedure. Individual variability of blood pressure is also very important. Lack of necessary skills for continuous independent pressure measuring. That's why you, like a doctor, should study your midwife how to correct measure the blood pressure, especially in a pregnant woman. When is a pregnant woman hypertensive? When? Of course, when your systolic blood pressure more than 140 and your diastolic blood pressure is more than 90 millimeters hydrergium, more than in Hypertension. A rise of more than 30 systolic and more than 50 diastolic. That's why her anamnesis is very important if she has chronic hypertension, if she uses glucocorticoid drugs, if she has another maybe secondary hypertensive disease. You should know about this. Knowledge of the prior blood pressure is very important. Not in itself diagnostic, look for other problems. In which case, we diagnosed severe hypertension. It may be one occasions of more than 160 systolic or more than 110 diastolic blood pressure. Only one occasions of such systolic and diastolic pressure. In this case, you have all rights to diagnose a severe hypertension. Requires admission and urgent to the maternity. However, the diagnosis is more important than the actual level of blood pressure. What is the classifications of hypertension or hypertension disorders in pregnancy? Chronic hypertension. This is the hypertension which woman has before pregnancy, or you can diagnose it before 20 weeks of pregnancy. In this case, you can talk about the chronic hypertension. Let's repeat. Chronic hypertension, it's a hypertension which women has before pregnancy. Maybe she has hypertension disease, or she has renal disorders, or she has another extragenital pathology which has clinic of the high blood pressure. Or you, during your measuring of blood pressure, You can diagnose high blood pressure before 20 weeks of pregnancy. It's very important. Preeclampsia and eclampsia. What is this? The main diagnostic signs is high blood pressure and proteinuria. Eclampsia is a convulsions. Let's talk about it at the end of the lecture. Preeclampsia superimposed upon chronic hypertension or renal disease. This is chronic hypertension plus proteinuria in the women which has chronic hypertension or renal disease or another extragenital pathology. Gestational hypertension. I pay your attention. This is hypertension only during pregnancy. In case of chronic hypertension, we discussed about the diagnosing before 20 weeks of pregnancy. But in case of gestational hypertensions, you can diagnose these definitions when you have high blood pressure after 20 weeks of pregnancy without proteinuria. The main diagnostic criteria, the absence of proteinuria and week of pregnancy more than 20 weeks. In this case, you can talk about the gestational hypertensions. And transient hypertension. This is condition only after pregnancy. After the delivery, she has high blood pressure and you can talk about this transient hypertension. Hope everything is clear for you. It's hard to me because usually I speak with you during lecture. Hope everything is clear for you. What is chronic hypertension? Defined as hypertension diagnosed before pregnancy, before 20th week of gestation, during pregnancy, and not result postpartum. This is your diagnostic criteria of chronic hypertension. Gestational hypertension. No proteinuria. After 20 weeks of pregnancy, systolic blood pressure more than 140 and diastolic blood pressure more than 90. No proteinuria. I repeat you one more because it's one of the main criteria of the diagnosing of gestational hypertensions. But in 25% of cases, we have the developing of preeclampsia. It's real situation. Diagnosis of gestational hypertensions detected for first time after mid-pregnancy. You know it clearly. I talk about it. No proteinuria. No, there is no protein in the urinary analysis. Only until a more specific diagnosis can be assigned postpartum. If preeclampsia does not develop and blood pressure returned to normal by 12 weeks postpartum, diagnosis is transient hypertension. We also talk about it. Blood pressure remains high postpartum. Diagnosis is chronic hypertension, and in case when you have proteinuria, of course, you can diagnose preeclampsia. The incidence of this severe pathology is near 21% of all cases of gestation hypertension disorders during pregnancy. What is preeclampsia? In which case you can diagnose preeclampsia or eclampsia. Occurs after 20th week. If earlier, please think about trophoblastic disease. You will have such lecture. This is not topic of my lecture, but please remember, if you have high arterial blood pressure and proteinuria before 20th week of pregnancy, please think about trophoblastic disease. Increased blood pressure. Gestational blood pressure elevation with proteinuria. This is the main diagnostic criteria of the preeclampsia: high blood pressure, proteinuria, and edema. This is the third diagnostic criteria of this. But edema is not part of these definitions. If you have only edema, it's not a preeclampsia. If you have high blood pressure, if you have proteinuria, and also you have a general edema, not local edema in the leg, yes, it's one of the diagnostic criteria of this pathology. Diagnosis. Their systolic blood pressure more than 140 and diastolic. Like an obstetricians in our clinic, we pay attention only on a diastolic blood pressure. Of course, the systolic pressure is also important in this diagnosis, but we pay our attention on the level of diastolic. When you have diastolic more than 90, yes, it's a hypertension during pregnancy. The second main criteria which we discuss with you is proteinuria. Is defined as urinary excretion. What is this? 0.3 gram proteins or greater during a day, 24 hours. Or +2 or greater on urine deep specimen. In this case, we can talk about proteinuria. Let's repeat. 0.3 gram protein or greater in a 24 hours, or +2 or greater on urine deep specimen. Blood pressure. Measure of blood pressure in a sitting position with the cuff at the level of the heart. Inferior vena cava compression by the gravid uterus while the patient is supine can alter readings substantially, leading to an underestimation of the blood pressure. Blood pressure is measured in the left lateral position. Similarly, male will yield falsely low values if the blood pressure is measured in the high arm and the cuff is not maintained at the heart level. The current positions of the cuff, the current position of the patient in the sitting. Also, we discuss about 2-3 minutes of relaxations for avoiding a white coat hypertensions, and other rules of measurements can help you to diagnose a correct blood pressure in your patients. Allow women to sit quietly for 5-10 minutes before measuring of the blood pressure. If you have a lot of time during her visit to you, of course, you have 4, 10 or 15 minutes, but in our country, the durations of the visit patient to the doctor is not more than 12 minutes. That's why, in my opinion, 2 or 3 minutes enough for relaxing of the patients, for her adaptations to their doctor's cabinet. And after that, you start to measure the blood pressure. Record Korotkov sounds, the first sounds and the five sounds, the disappearing of sound, to denote the systolic blood pressure and diastolic blood pressure respectively. Of course, in about 5 women, an exaggerated gap exists between the fourth muffling and fifth disappearance Korotkov sounds, with the fifth sounds approaching zero. In this setting, record both the fourth and fifth sounds, but usually we use Korotkov first sound for the measuring of systolic blood pressure, and the 5 Korotkov sounds, the full disappearance of sounds in case of diastolic blood pressure. What is the classifications of preeclampsia? We have only 2 forms: mild preeclampsia and severe preeclampsia. Only 2 forms. Please pay your attention during answer on your classes or during your answer in an exam, especially for me. What is the diagnostic criteria for severe preeclampsia? I pay your attention. Usually you have only one diagnostic criteria, and it's a main criteria for the diagnosing of this severe preeclampsia. When you use and have your systolic blood pressure more than 160, and when you have your diastolic blood pressure more than 110. Proteinuria more than 5 grams during 24 hours, or if you're a doctor in the village hospital and you have no possibility to evaluate the amount of the protein in the urinary, you can use special urine dip, and when you have more than 3 plus urine dip, this is also one of the criteria of severe preeclampsia. Of course, oliguria, less than 400 millimeters in a 24 hours. This is also the criteria of severe preeclampsia. Please pay attention on your complications, visual changes. It's very important and a very severe complications of preeclampsia. Of course, a severe headache. If she has a severe headache and a blood pressure more than 160 and more than 110, please remember about severe preeclampsia. Scotometer, of course, visual changes. Changes in the mental status. It's also a very, very severe complications during preeclampsia. Pulmonary edema, also a severe complications. And of course, it should be, this woman should be admitted immediately to the hospital. Epigastric pain. When I talk with their family doctors or with the therapeutists or with the students, epigastric pain during pregnancy, it's not a gastritis. Please think the epigastric pain sometimes is the one sign. You have no high blood pressure, you have no proteinuria, but she has complained on epigastric pain. What is this? It's preeclampsia. Please remember about it. During an hour after the appearance of these pains, she will have high blood pressure, she will have a severe proteinuria, and maybe during 2 or 3 hours it's ended with the convulsion. That's why the epigastric pain during pregnancy, it's not a chronic gastritis, it's not an acute gastritis, it's one of the criteria of severe preeclampsia. Please remember about it. Also, impaired liver function tests, of course, ALT, AST, the elevation of these tests, it's one of the criteria of severe preeclampsia. Also, thrombocytopenia. That's why the general analysis of the blood helps you in it. Please think about the mother, of course, and the child. Intrauterine growth restrictions with or without abnormal Doppler assessment. That's why it's very important to use an ultrasound machine with the Doppler. Of course, also you need to have a colic with their appropriate qualification. It's very nice if you're an obstetrician and an ultrasound doctor. Good, perfect. You can do it by yourself. But if you cannot do the ultrasound nowadays, please ask your colleague who have appropriate qualifications in it for the diagnosis of an intrauterine growth restriction. It's very important and is one of the signs of preeclampsia. Olighydramnions. Also, during an ultrasound investigation of the fetus, it's one of the additional criteria. It's not a main criteria for preeclampsia, but it's one of their additional criteria for the diagnosis of this disease. Another definition: classification of preeclampsia are superimposed upon chronic hypertension. Hypertension and no proteinuria before 20 weeks, new onset proteinuria after 20 weeks. If after 20 weeks of pregnancy you have proteinuria in her urinary analysis, this is a preeclampsia superimposed upon chronic hypertension. Hypertension and proteinuria before 20 weeks. Sudden increase in proteinuria, sudden increase in blood pressure. For example, she has hypertensive disorders. She uses hypertensive pills. Everything is okay, but suddenly she has high blood pressure using a standard hypertensive pills. Please think about preeclampsia. If you have no effect from her standard hypertensive therapy, if you have no possibility to control her high blood pressure using standard hypertensive therapy, please think about preeclampsia upon chronic hypertension. Of course, if you have a problem with the thrombocytopenia, if you have changes in her general blood analysis, of course, it's one of the criteria of preeclampsia. And increasing of liver blood levels, it's also one of the criteria of preeclampsia upon chronic hypertension. Preeclampsia ranged from mild to severe. Progression may be slow or rapid, nobody knows. It may be during 1 hour, it may be during half an hour, it may be more than 1 hour, 2 days, 2 weeks. Progression may be so fast or may be slow. For clinical management, preeclampsia should be early diagnosed to prevent maternal and perinatal morbidity. Of course, nobody wants to have maternal death. In our country, we have a big problem in our obstetrical staff when we have maternal death. It's amazing when you can to avoid this problem. And of course, mortality primarily through timing of delivery. Pathophysiology of importance and distinguishing preeclampsia from chronic or gestational hypertension is that preeclampsia is more than hypertension. It's a systemic syndrome, as you understand from my previous slide, and several of its non-hypertensive complications can be life-threatening when blood pressure elevations are quite mild. The maternal disease is characterized by vasospasm. That's why clinically you can see high blood pressure due to vasospasm. Activation of the coagulation system. If the activation is big, you can see thrombocytopenia in your general blood analysis. I hope it's clear for you. Perturbation in humeral endocrine system related to volume and blood pressure control. Oxidative stress and inflammatory-like responses, and pathologic changes that are ischemic in nature. Of course, ischemic, then vasospasm, then biologically active substances, then prostaglandins and other substances, and we have the problem like hypertension disorders. What changes we can see in a heart? Generally unaffected. Cardiac decompensations in the presence of pre-existing heart disease. And I pay your attention one more. Please ask patient about her previous disease. Dear ma'am, maybe you have heart disease. Maybe you have kidney disease. Maybe you have a problem with the connective tissue. Maybe you use some drugs. Please show me if you have it, or show me maybe a previous doctor's recommendations. It's very important. And you can see if she has no pre-existing heart disease. In this case, heart generally unaffected, and we have no problem with the heart function. Good. Let's talk about kidney. Yes, renal lesions, especially glomerular endotheliosis. Renal blood flow decrease. That's why you have hyperuricemia. Proteinuria may appear late in clinical course. Hypocalciuria. Alteration in calcium regulatory hormones. Impaired sodium excretion. Suppression of renin-angiotensin system. If we have changes in renin-angiotensin system, Yes, we have a high blood pressure due to pathophysiological changes. Hope clear. Coagulation system. Thrombocytopenia, low antithrombin 3, higher fibronectin. Due to the hypercoagulations, like one of the pathophysiological mechanisms for the origin of this pathology. One of the severe complications of preeclampsia is HELP syndrome. What does it mean, HELP? H mean hemolysis, E elevated liver enzymes ALT and SAT, and LP, this is low platelet count. What does it mean, HELP? One more. H hemolysis, EL elevated liver enzymes like ALT and SAT. You can evaluate it during your biochemical analysis of the blood. And LP, this is the low platelet count. Believe me, it's a very severe complications which lead to the maternal death. And eclampsia, also a very severe complication of this pathology. What does it mean, eclampsia? What is definition of this problem? Eclampsia is the convulsive phase of preeclampsia. Symptoms may include headache and visual disturbances, included blurred vision, scotometer, and rarely cortical blindness. Eclampsia is a convulsive phase of preeclampsia, a very severe complications. Physical findings in preeclampsia: high blood pressure, systolic more than 140, diastolic more than 90, proteinuria more than 1.3 grams in a general urinary analysis, or more than 0.3 grams during a urinary analysis during a 24 hours. Retinal vasospasm or retinal edema, right upper quadrant abdominal tenderness, stems from liver swelling and capsular stretch. Also a very like a stomach ache. When she comes to you and said, "Doctor, I have problem and I feel discomfort in the right abdominal area, or I have stomach ache," and if she is pregnant, please think about preeclampsia. It's not a problem with the liver, it's not a problem with the stomach, it's not a gastritis and hepatitis. It's a problem with this organ due to the preeclampsia. A few words about edema, in which case we can speak about the edema like one of the criteria of this pathology. Not in the majority of cases, because as you see on this slide, edema of the arm and the leg is a common situations for the majority of pregnant women. This is a normal physiological reaction on an increase of circulating blood volume and body weight during pregnancy. Edema of the arm and the leg is a common, but if you have the presence of the edema when it suddenly appears or if you have generalized edema, sorry for my English. In this case, it's one of the criteria of the diagnosis of the preeclampsia. If you have only edema of the arm and the leg, it's not a criteria for the diagnosis of preeclampsia, and the majority of cases it leads to the overdiagnosis. Proteinuria, like a criteria of preeclampsia, more than 0.3 gram per day or more than 0.3 gram during 24 hours. When you have level of urinary protein more than 0.5 but not higher than 5 gram, this is moderate proteinuria. What is the diagnostic criteria of severe proteinuria? Is the protein level more than 5 gram during 24 hours, or if you have no your lab possibility to determine the level of your protein in the urine, it's more than 1 in 2 portion of urine taken at interval of 6 hours, or a 3 plus value on a test strip. If you work at the village hospital, maybe you have no laboratory, you have only a test strip. If it's 3 plus, yes, it's a severe proteinuria, it's one of the criteria of a preeclampsia. Symptoms of preeclampsia. Visual disturbances typical of preeclampsia are scintillation and scotomata. These disturbances are presumed to be due to cerebral vasospasm. We're talking about the vasospasm like one of pathophysiological mechanism of preeclampsia. In case of cerebral vasospasm, your patient has visual disturbances. Headache. Headache is of a new onset and may be described as frontal throbbing or similar to migraine headache. However, no classic headache of preeclampsia exists. When it's sudden, if she suffered from the sudden headache, when she has high blood pressure, please think about preeclampsia. Epigastric pain is due to hepatic swelling and inflammations with threat to the liver capsule. Pain may be of sudden onset, it may be constant, and it may be moderate to severe in intensity. Sudden epigastric pain or a constant epigastric pain from moderate to severe, yes, it's one of the symptoms of preeclampsia. While mild lower extremity edema is common in normal pregnancy, we talked about it in a previous slide, rapidly increasing or non-dependent edema may be a signal of developing preeclampsia. However, this signal theory remains controversial and recently has been removed from most criteria for the diagnosing of preeclampsia. Please pay attention on her rate. Rapid weight gain is a result of edema due to capillary leak as well as renal sodium and fluid retentions. That's why very important to discuss with your patient and ask the main questions which help you to diagnose this severe problem of obstetrics. Physical findings in preeclampsia. Brisk or hyperactive reflexes are common during pregnancy, but clonus is a sign of neuromuscular ability that raises concern. Among pregnant women, 30% have some low extremity edema as part of their normal pregnancy. However, a sudden change in dependent edema, Edema is non-dependent areas such as the face and hands, or rapid weight gain suggests a pathologic process and warrants further evaluation. Differential diagnosis. Documentations of high blood pressure before conception, so before gestational week 20, favors the diagnosis of chronic hypertension. Essential or secondary, it depends on her anamnesis of victim. High blood pressure presented at mid-pregnancy, after 20, after mid-pregnancy, may be due to early preeclampsia, transient hypertensions in case of postpartum high blood pressure, or in a very rare cases we can talk about unrecognized chronic hypertensions. This is the main differential diagnosis between hypertensive disorders. Also a thrombotic thrombocytopenic purpura. You have general blood analysis, you have no high blood pressure, you have no edema, you have no proteinuria, but you have thrombocytopenia. Of course, you should exclude blood coagulation pathology. Please think about hemolytic uremic syndrome, acute fatty liver of pregnancy. Yes, it's not so good conditions, but in differential diagnosis with preeclampsia. Laboratory tests. Please pay attention on hematocrit. In case of preeclampsia, the level of hematocrit will be higher due to their hypercoagulations, hemoglobin, serum of uric acid, also urinary blood analysis with the evaluation of proteinuria, baseless sonogram at 25 to 28 weeks. Patients presenting with hypertension before gestational week 20, some tests as described for high-risk patient presented with normal blood pressure. Early baseline sonography for dating and fetal size. Good if you have in your clinic ultrasound machine with the doctor and a high-quality specialist in ultrasound. Better if you are a specialist in OB-GYN and also in an ultrasound. Your eyes is your eyes. The eyes of your colleague good, but it's not your eyes. That's why the ideal positions, if you have to do all, it's easy to correct diagnose this pathology. Quantification of protein excretion. Hemoglobin and hematocrit and platelet count. Of course, please evaluate serum creatinine, uric acid and transaminase level. Serum albumin, blood smear and coagulation profile. This laboratory test is very important in patient presenting with hypertension after mid-pregnancy. The treatment of preeclampsia the main goal of treatment of this very severe pathology, of course, prevention or avoiding a convulsion or preventing of eclampsia and of course other severe complications of this pathology. Attempts to treat preeclampsia by natriuresis or by lowering blood pressure may exacerbate pathologic changes. Palliate maternal conditions to allow fetal maturations and cervical ripening. Maternal evaluation. Girls. Of course, early recognition of preeclampsia. It helps you to avoid severe complications. Observe progression both to prevent maternal complications and protect well-being of fetus. Early signs. Blood pressure rises in late second and early third trimesters. Initial appearance of proteinuria is also important and may be one of the early signs of preeclampsia. Often, hospitalization recommended with new onset preeclampsia to assess maternal and fetal condition. Hospitalization for duration of pregnancy indicated for preterm onset of severe gestational hypertension or preeclampsia. Ambulatory management at home or a daycare unit may be considered with mild gestational hypertension. Only in this case. When you diagnosed preeclampsia, it's only inpatient department, and of course an urgent hospitalizations for the correct assessment of maternal and fetal conditions, and in case of diagnosed complications you have conditions to treat this woman and to do the delivery. Ambulatory management only in case of gestational hypertension. If you have preeclampsia, sometimes mild preeclampsia, please go to inpatient unit and only the urgent hospitalization in case of severe preeclampsia. How we can monitoring of fetal conditions. You have a stethoscope. You know about this instrument from the ancient. We use it nowadays. It's good. Fetal heart auscultations. Of course, CTG in our town, in our maternities, each department has CTG. In case of a coming woman to inpatient department, we use continuous CTG until the stabilizing of arterial blood pressure of this woman. It's good, it's perfect if you do ultrasound with the Doppler. It's easy to you to evaluate the condition of the fetus. Is enough blood for him or not? What is her conditions? Does he feels ischemic problem? Does he has hypoxia? If everything is okay, good. But if you have a distress, you should do an urgent cesarean sections. Or if you have appropriate conditions, you should start the delivery. What is very important during an ultrasound? Of course, it's fattometry. Of course, you should evaluate amniotic index for a diagnosis of polyhydramnion. I talked about you on the previous slides because polyhydramnion is one of the additional criteria for a preeclampsia. And of course, placentametry. Is it good with placenta? Everything is good or it has changes? Please, if you have pregnancy, more than 24 weeks of pregnancy, up to 34 weeks. Also, like an addition to the main treatment of preeclampsia or hypertension disorders, you should prevent a respiratory distress syndrome. This position has in worldwide guidelines, in Russian guidelines, in Ukraine guidelines. I hope in your countries also you have such guidelines. The basic therapy of preeclampsia and also a prevention of respiratory distress syndrome in case of preterm delivery or in case of severe preeclampsia and you should stop this pregnancy. But of course, this fetus can't to breathe properly. That's why you should avoid respiratory disorders and prevent respiratory distress syndrome. How? You have glucocorticoids. For example, betamethasone, 12 milligrams intramuscularly with the interval of 24 hours. Also, if you have no betamethasone, you can use dexamethasone, but it's another scheme. 6 milligrams every 12 hours during 2 days. I repeat, if you use dexamethasone, 6 milligrams intravenously with an interval of 12 hours during 2 days. That's why the summarized dose of the dexamethasone is 24 milligrams during 2 days. This scheme is for the prevention of respiratory distress syndrome. Preeclampsia. Antepartum management of preeclampsia. Little to suggest therapy alters the underlying pathophysiology of preeclampsia. Restricted activity may be reasonable. Sodium restrictions and diuretic therapy appears to have no positive effect. Please don't use diuretics in case of hypertension disorders, in case of severe preeclampsia, and in case of convulsions. Indications for delivery. Maternal. Gestational age 38 weeks or over. If you have thrombocytopenia, severe progressive deterioration in liver and renal function, suspected abruptio placenta, persistent severe headaches, visual changes, nausea, epigastric pain or vomiting. These clinical signs say you about of severe preeclampsia and you should deliver this woman. Of course, delivery should be based on maternal and fertile conditions as well as gestational age. It's very important for us obstetricians because nobody likes preterm delivery. It's a very big problem of a preterm baby. Good if you have full-term pregnancy, and of course you know there is no respiratory disorders of this baby you will have in the future. Of course it's good. Indications for delivery in preeclampsia. Severe fetal growth restriction. Please evaluate the condition of the fetus using by ultrasound with the Doppler. Non-resurgent fetal testing results, and all severe polyhydramnios amnions, but delivery should be based one more on maternal and fetal conditions as well as gestational age. The cure for preeclampsia is delivery. The cure is always beneficial for the mother, also cesarean section might be needed. That's why you should have a doctor in your staff with appropriate qualifications who can do an urgent cesarean section. The cure may be deleterious for the fetus. Route of delivery. Vaginal delivery is preferable. Aggressive labor inductions within 24 hours. You can use neuroaxial epidural, spinal, or a combined spinal epidural techniques of advantages. In our clinic, we use these techniques, very successful. Hydralazine, nitroglycerin, or labetalol may be used of the pre-treatment to reduce significant or severe hypertension during delivery. This is a high-risk labor. In our country, we can do delivery of such women only third level of organizing of obstetrical and gynecological. Why? Because you should have appropriate conditions for delivering. You should have a special resuscitate unit for a newborn, especially in case of preterm delivery. Also, you have appropriate staff of anesthesiologist and an elder colleague who can help you if you have a complications during delivery. That's why in our country, this is the third level of obstetrical and gynecological aids. This is perinatal center. It's one of our clinical base of our department. It's located in Simashka Street, Building 6. Such women with severe preeclampsia have their delivery in this maternity because we should have special conditions for the delivery of such women. Anticonvulsive therapy indicated to prevent recurrent convulsions in women with eclampsia or to prevent convulsions in women with preeclampsia. Parenteral magnesium sulfate reduces the frequency of eclampsia and maternal dearth. Caution renal failure. Prevention of convulsions, it's of course intravenous administration of magnesium. This is the scheme for you. Introduce magnesium 25% 20 milliliters intravenously slower over 10 minutes in a 2 milliliters through an infusomat at a rate of 2 grams per hour. Please use only solution of natrium chloride or another crystallite fluids. After that, please continue the infusion at a rate of 1 or 2 grams per hour. Please don't stop therapy. It should be continuous for 24 hours after childbirth or after the last seizure in case of eclampsia. You should control your therapy. How? You should evaluate diuresis per hour each hour, respiratory rate, oxygen saturations and knee reflexes, and if it's possible, please evaluate of serum magnesium levels daily with continued infusion more than 24 hours. During an infusion, Blood pressure measurement should be every 15 minutes. You should evaluate heart rates, observation of breathing frequency at least 15 per minute, determination of oxygen saturation not less than 95. You should have cardiac monitoring, ACG. You should check knee reflexes every 10 minutes for the first hour, 2 hours of infusion, and then after 30 minutes during an infusion. Of course, urinary catheter and control of urine output every hour. If you have the overrate of magnesium sulfate, antidote is calcium gluconate. The rules of 310: 10% of calcium gluconate, 10 milliliters intravenously for 10 minutes. It's easy to remember the rules of 310. This is the antidote in case of hypomagnesemia. 10% calcium gluconate, 10 milliliters intravenously for 10 minutes. Treatment of acute severe hypertension in pregnancy. Parenteral magnesium sulfate is most commonly used. We discuss. The diagnostic criteria: systolic blood pressure more than 160 or diastolic blood pressure more than 110 or 105. Maybe you can use parenteral labetalol as a second line drug, avoiding the women with asthma. Please be careful. Oral nifedipine used with the caution: short-acting nifedipine is not approved by FDA for managing hypertension. You can use nifedipine only in the case of emergency decreasing of your high blood pressure. Sodium nitroprusside may be used in rare cases in case of maybe allergy for magnesium or another problem with the using of magnesium. Of course, or you like a second line drug, you can use sodium nitroprusside. Please don't use atenolol. Why? Because maybe distress of the fetus, iatrogenic distress of the fetus. And when you use atenolol for a long period of time, maybe the increase in tone of hypermemetrum, and you can have iatrogenic preterm delivery or threatened abortions due to the using of this drug. Please don't use angiotensin inhibitor converting enzymes and angiotensin receptor blockers. Please don't use diuretic, because in a case of hypertensive disorders, woman has hypovolemia. And when you use diuretic, you can have iatrogenic acute hypovolemia. And of course, a dangerous side effect may occur when you use diuretics. And the last one, this is eclampsia. It's disaster, believe me. I saw this when I was a young doctor. We should avoid this. It has 4 periods or 4 stages. Preconvulsive period, 30 seconds, small twitching of the muscles of the face, the eyelids close, the corners of the mouth drop. Then preconvulsive period, very rapid change on the period of tonic convulsions. It's a tetanic contractions of the muscles on the whole body, breathing stops, and the face turns blue. The durations of each period you can see only 30 seconds. It's very rapidly, believe me. and it's a disaster. Period of chronic convulsions. After that, seizure resolution period. A woman does not remember anything that happened. It's also differential diagnostic in case of other psychiatric pathology. The first aid is ABC. Treatment begins immediately. You should hospitalize the pregnant women in anesthesiological department. The patient is laid on a flat surface in a position on the left side. Quickly release the airways, opening the mouth and pushing the lower jaw forward. Evacuate oral contents. If you have spontaneous breathing, enter the oropharyngeal duct and carry out inhalation with oxygen, applying another facial marks. Good if you're a doctor of inpatient department. It's not so good if you are a doctor of an outpatient department. Of course, you have no oxygen. Yes, you have oropharyngeal duct, but it was too hard for you to find the oxygen and other facial masks in case of your doctor in outpatient department. The rules of 3 catheter. With prolonged apnea, forced ventilation with a nasal-facial mask with a supply of 10-100 oxygen in the positive expiratory pressure mode. When seizures recur or coma persists, muscle relaxant are introduced. In parallel, peripheral vein catheterization and introduction of anticonvulsant therapy. And the third catheter, it's a blood catheter. Intravenous catheter, blood catheter, and intubation. This is the rules of 3 catheter. This is the first urgent aid of preeclampsia. Don't forget about women after delivery. You should consult her for the future pregnancies. Risk of recurrent preeclampsia increases. Yes, preeclampsia before 30 weeks. In case of multiple pregnancy, as compared with nulliparis or new father. Risk of recurrent preeclampsia may be greater in African Americans. Please consult her if she has a previous preeclampsia. Prognosis. The more certain the diagnosis of preeclampsia, the lower the prevalence of remote cardiovascular disorders. Of course, in subsequent pregnancies helps define future risk and help a doctor. Gestational hypertension in any pregnancy increases remote cardiovascular risk. Guys, thank you very much for your attentions. This is all what can I say for you. I hope my lecture will be useful for you when you have your classes and you will meet with you on exams. Believe me, it's a very disaster pathology, and all obstetricians don't want to have such patients. I wish you good luck. I hope you will be a good doctors and you will know how women with such disorders, but in case if you have such women, after my lecture you know what to do. I wish you a good day. Thank you for your attention. Галя, я закончила.